Okay, Madeline, are we good to go? Okay. Hello, everybody, and welcome to the second GICS webinar. I'm not going to mention the time of day because it's different for everybody. As we know, we're in different phases of COVID, and in our first webinar, we talked about what were the challenges for children during this period. And on this occasion, we're going to look at and discuss what are the what GICS can do to help with these challenges. Now, as I said earlier, that we know things are evolving in each country. So while we speak, we might be outdated already. What we plan to do in this seminar is to talk about how GICS can help under the following headings, which is educational, resources, guidelines, backlog of patients, and research. And we have 8 panel members who will discuss this topic for this time. Next, Madeline. Next slide, Madeline. So once again, I'd like to thank Livebox for hosting this platform. And these are all our collaborators and sponsors who are working with us to make things better for children around the world that need surgery. Next slide, please. The way we're going to run it is we're going to talk about what are the greatest challenges facing you, which we've already done in the previous webinar. And on this one, it's what GICS can do to help. So during our last webinar, we talked about the backlog of surgery, how children were sidelined during the COVID crisis, and what impact it has had on surgical children. Next one. And then also looking at how a lot of the public stayed away from hospitals out of fear, where hospital visits were reduced and also patients didn't attend clinics, and that further increases the morbidity for our children. Next slide, please. And I think the last point was there was a lot of discussion about PPE and education. So we hope that today's webinar will look at these topics and how GICS could help within these topics. Thank you, Madeline. So like the last time, we moved from crisis from east to west, and we're going to do the same for this time round, having our panelists starting from the east.
Thank you. I think what I sort of talked about in the last GICS webinar was that, you know, in Hong Kong, we were quite fortunate in that we had experience of, you know, tackling this pandemic from 17 years ago, from the first SARS pandemic, which was quite localized within the Asian community in Asia, in Hong Kong, as well as in China. So we learned from that, and for this time round, we sort of mobilize our resources, and we sort of put in plans well ahead. But little did we know that it was going to be such a huge scale. Now it's over like 10 million people affected with this virus worldwide, and it's still showing no sign of sort of peaking in many countries. In fact, in America, it's still reporting like 50,000 cases per day. In terms of us in Hong Kong, we were quite fortunate in that we only had 1,000 cases in a population of 8 million people, which is very, very low. In children, we only had about 90 cases, and all of them actually were very mild, and most of them have gone home and got discharged. So in that sense, we knew that we could reopen our services. In fact, we opened our elective surgery 1 month ago, sort of 1st of June. And there is some backlog, but we haven't had a huge backlog like many countries are facing. You know, we probably, you know, could catch up within the next 4 to 5 months if we do it in the usual speed that we used to do it before this pandemic. So we are okay with that. But I think what we need to do in terms of education is, because we've had 6 months of no student attachment to the hospital, so they are seriously lacking in clinical skills. This applies to medical students as well as to our trainees as well. The trainees were not allowed to go into theaters to operate. So this is an issue. For patients and carers, we talk about them not coming back to see doctors because of the fear of the virus. So this is something we should do about it. We should provide public education in newspapers, in radio shows and TV shows, as well as webinars, so that they know that if measures are put in place properly, they should be pretty safe to come into hospital, at least in our setting anyway. So for pre-op testing, we are still hoping to get everybody tested in the whole population. This is easier said than done. Number one is the sort of like the lack of reagents worldwide. Number two is this time scale of performing each test, get the results. Number three is if you're doing saliva only, if you're negative today, it doesn't mean that you won't become positive the day after tomorrow. So you have to do repeat testing before the operation. In fact, when we go into another hospital outside Hong Kong and China, for example, to visit, we have to send our specimen sample saliva twice, one today and one in 3 days' time, just for the visit to China in a week's time, so that they know we are negative for the virus. We know that some people are persistent excreted as well. So we need funding for extra equipment, for example, disposable PPEs, face masks, face shields. Most importantly, it's very expensive to do the COVID-19 testing for many countries. And for countries which are very have a huge backlog, I don't know how it's possible, whether we can redistribute the cases to other units in the same country to help out each other rather than holding on to cases yourself. Research-wise, I think we need to look at seriously the children who have been infected by the viruses, because although their symptoms in the acute phase are pretty mild, there are evidence now in the literature coming out for the past few months that children, long-term wise, in the medium term and long-term wise, they do have some sort of issues in terms of mental health, long-term inflammatory conditions as well. So there are things that we need to look at in terms of research, as well as looking at how big a scale is the backlog of the operations. So this is all I wanted to say for tonight. Thank you.
Is it my turn? Hi, can you hear me?
Yes, we can, Beda.
Okay, I think this is my turn. So I have to answer one by one the questions that Marilyn gave me. For the first question, for the educational resources, what topics and formats would benefit? So the hot topic that we need right now, just the safety of conducting a surgical operation of children, usually using the minimally invasive surgery such as laparoscopic or thoracoscopic. And of course, the issues of delivering safe teaching methods for residents. Currently, we are conducting lectures for residents through online meetings. So for the safety conducting surgical operations, because as we know that we still have not a consensus for what kind of safety operation that we can do for the children. So for example, in my institution, even though some of my colleagues still using the PCR for a standard for operation, but at the other case, we cannot do the PCR. Usually we just do the rapid test and the CT of thorax, and after that the patients can be operated. That's all. And for the second question, what specific issues should be addressed? The guidelines in the guidelines for children's surgical care during the pandemic. The most important issue is the safety and protocols of procedures for pre-operation, intra-operation, and post-operating care. That's the most issue and the most important for us, especially in Indonesia right now, because as you know that Indonesia is a big country, and even though we still have little pediatric surgeons in Indonesia, but we have, you know, in every institution we still have our own procedures to make an operation for the children. So I think that's the most important thing right now. We have to make a consensus what kind of surgery that's safe to the children. And how can GICS help now after elective operation resume, after travel restrictions are lifted? So GICS can help with the development of protocols during this pandemic and also assist with the teachings of residents and the dissemination of knowledge throughout the countries. And after elective operations are resumed, GICS can always assist or continue assisting in the training of pediatric surgeons everywhere and the exchange of knowledge and skills through online media. And after the travel restriction is lifted, GICS can always support developing countries such as Indonesia, of course, through collaboration of research and trainings of pediatric surgeons, as Madeline did for me a time ago. And what action-oriented research is important right now, and what information has already been gathered in my setting, and what information should be gathered now. We need research on safety of procedures. What safe alternatives that we can apply to keep meeting the demand of pediatric surgery, at the same time keeping the patient and the health worker safe. And GICS can initiate the different alternatives that can be conducted in these times. For instance, the use of laparoscopic is safer than laparotomy during the pandemic. This is still a big question mark, because in some, I've read some journal that laparoscopic is safer than laparotomy, but it's still debatable right now. So that's all. Thank you.
Good evening. Can you hear me?
Yes, we can.
Yeah, okay. I also answered the 4 questions that was emailed to us by Marlene. First is how can GICS help as far as educational resources are concerned? For me, I divided this into 2 categories. One is education for GICS members like us. So the following topics I suggested are updates on issues on new topics on pediatric surgery, if this is possible, like what APSA is doing, and maybe GICS also going to follow through. And tumor board conference maybe is one of them, maybe quarterly or once once a year is also very beneficial for us here. And number 3 topics that how I do it videos. You know, many of us maybe in not only in the low middle income countries or high income countries, there are some tricks how to do a particular procedure. Maybe you can share it to us and we can share it also to you. So these are particular topics. Now for formats, the same, webinar, live streaming, and YouTubes. Now for the next, please. For the trainees and residents, next slide, please. Can I have the, Marley, can I have the next slide? No, the second slide, please. Okay, so this for, as I said, I purposely divided it in two categories. One is for the GICS members, and the other one is for the trainees and fellows. Now, for the fellows and trainees, we could at least give the GICS could give some lectures or neonatal and pediatric surgery to add their cognitive knowledge, especially now with pandemics. Maybe give them also, or maybe design a teaching curriculum with modules for the trainees and maybe give some pre and post tests that will be very helpful to them. And there are also some skill simulation training videos for trainees. Maybe the HIC can share it to us. Format of this may be the same, webinar or Zoom or some conferences like this what we're doing right now. Next slide. So for how can GICS help as far as guidelines are concerned? So I think every institution that we are here in many countries have their own particular guidelines and some are hospital-based. But I would suggest that GICS should maybe design or propose some guidelines with respect to the following issues, like how to prepare patients for elective surgery that now have started, the important role of the RT and PCR testing, and other types of rapid testing, which is still controversial right now. And also the prioritization of kind of surgical cases that we will do during this pandemic, especially for coming elective cases. And also issues on correct and proper physical setup of the OR, and also issues about the safety of healthcare personnel. Although we have this in the institution, we would like to see how can GICS suggest on this particular point of issues. Next. Now, regards to the backlog of patients, you know that we have a lot of backlogs for the past 3 months, and we are trying to do here that open the elective surgery. But I think again, GICS could give a suggestion or guidelines on how to possibly increase the census of surgical cases, minimize the backlog, but of course all the safety precaution that we are doing now. And maybe the next is, I think everybody is pointing on this, that said GICS could also help us in providing us funds for to purchase the much needed PPEs, goggles, and everything that we still until now we're lacking, especially in the low middle income countries. No, and after this travel restriction has been lifted, I would suggest that again the high income country surgeons or members of GICS should still to continue to support us coming from the low middle income countries to still attend and participate in conference at what the WOPAPs are doing care of some. Next slide. So how can GICS help as far as research is concerned? Research, especially now, what we're going to do is that I think we should take on action-oriented research, what we have now, on the profile of pediatric surgical cases that have been done during the past pandemics, both for the HICs and the LMICs. And also another area point action research is the factors affecting the survival of children operated on with COVID-19, even emergency or elective cases. Next slide. So what have been gathered now already as far as concerned for research, as far as every institution as we have here in the country, we have already data on the number of types of cases that we have done and the outcome during these 4 months of lockdown. Maybe we could have this data could be shared to us, everybody, and compare notes for this. What is the best gathering method for this information? I think everybody experienced what the Red Cup has done, and then how can GICS help? And GICS could initiate and maybe fund a multinational international study commissioned by GICS for a research group to use and utilize Red Cup data to steer and initiate this kind of research. I think this is all. Thank you very much for the attention.
Thank you, Dr. Beda. Before Dr. Lubna comes in, I'd just like to mention, please use the chat for questions and discussions, because that will be very vital for when we move on in the discussion phase.
Ukila, do I have permission to start?
Sorry, yes, please do.
Right, okay. Good day and Assalamu alaikum to everyone. It's absolutely fantastic to see that there are 91 participants to this meeting so far. But that kind of belies the first point that I wanted to share. This is the feedback that I got from my colleagues. And I think I can speak for myself that the format that people are asking for to learn and increase the body of knowledge is more interactive sessions with small group discussions in which there is an ability to communicate the day-to-day challenges that surgeons are facing in the field, as opposed to webinars like this, which are a bit top heavy in that there are panelists speaking to people, and at the end of it, however much we try, there is less of an opportunity to for everyone to get their questions across or to initiate a truly interactive discussion. The topics really would span the entire spectrum of the management in the COVID era. I think what we're seeing as a medical community is something unprecedented, in which there is a disease that has appeared barely 6 months ago, and there is a body of evidence that is being created rapidly in front of our very eyes. So the entire spectrum of management really requires us, we're now used to looking at best practice guidelines that are based on evidence gleaned through years and years of refining literature, of data, of studies looking at finer points. And all of a sudden, we're having to gather that information and create guidelines of it in a matter of weeks to months. And I think that is really the challenge that we are facing, all of us, in how to keep up to date with this body of knowledge as it evolves. Things that were not known 2 months ago are now guidelines. How do you keep track of that? So the topics would need to be looking at this process iteratively and updating all aspects of precaution, risk categorization, and management aspects. The next slide, please. Could I have the next slide? Yes, thank you. How can GICS help with the guidelines? I think, again, the guidelines that we need is very importantly, and this is, I think, something that has been said by the speakers before me, what do we do at this phase when we realize we're into this for the long haul? COVID is here to stay. How do we restart elective surgeries in our practices? Because that backlog is very much, collecting. And I think all of us know anecdotally that there is a huge unmet need that is being sidelined right now, either because patients are unwilling to come in or because hospitals don't have the capacity to deal with elective cases. Specifically, what are the precautions that we're taking both in COVID and non-COVID patients? Specifically, laparoscopic surgery and laparotomies have raised a lot of questions on is it safe or not? And again, I think as an earlier speaker mentioned, what are the surgical and the medical manifestations in children that are secondary to COVID and are not presenting acutely but are presenting as delayed manifestations of the disease? Next, please. As far as the backlog, again, I think speakers before me have covered this. Financial resources to help public sectors deal with this backlog that is going to come up. I think importantly, we need support at all HR levels, not just for the surgeons. It's very important to make sure that the anesthesia, the technicians, the nursing staff are also facilitated because, at this meeting, we're really surgeon anesthesia specialist heavy, but the learning and the resources need to be designed to cater to all levels of the surgical teams and also the support teams helping surgeons. Next, please. I think the research is, in addition to to kind of working on gathering specific evidence that we need to guide clinical practice, we also need to start looking at the community-based need assessment and also look at how COVID patients are being impacted in terms of surgical outcomes. These are key areas, but I think as a group, we've really been looking at multiple areas of evidence gathering that needs to be done and needs to continue being done as the disease its manifestations, and our knowledge of it built up over the coming years. Thank you.
Hello. Hello.
We can hear you.
Am I audible? Great. So, looking at the various questions that you were asked, so the first one is how could GICS help us with educational resources? Looking at what is going on currently in the department, I noticed that most of the postgraduates and fellows have stopped listening to actually quite informative webinars. And I think what they lack is the structured courses, which can be even 2 to 3 times a week, like we used to do before for them. And these should include practical exercises like reading X-rays or coming to clinical diagnosis or giving them problems to solve on how to treat patients. This would actually catch their attention and improve their participation. And I think GICS could develop certification courses in specialities, which gives a certificate at the end of like a 2-month course or something like that. And though it would require a lot of input from GICS faculty, it will give a sense of achievement to the students who are doing the course, and they feel that they have actually learned something at the end of it, as well as will be a feedback to the faculty to know what they're learning. And this can be best done as webinar with interactive components such as exercises, tests, and participant responses. Other thing that would be great would be skill upgrades, though it is difficult to now produce YouTube videos of procedures in each subspecialties. I think there are enough that have been made in the past which can be utilized. So not new videos, but old videos can be used for this purpose. And then coming to how else the GICS could help would be providing information in our website, providing all information and recommendations. It took me a long time to find out that DDIs for hypermobility can actually indicate need for very early anticoagulation in symptomatic patients and save lives and save them from having a lot of complications. But if it is all available in one place, then it really helps a lot. And because each country and region has their own guidelines for PP testing, quarantine, and treatment, not all of these resources will be available in LMIC settings, but people can look at them and choose and see. So looking at the GCS help with guidelines, I think there should be such LMIC representation, know what is available in practical, and so also you have guidelines regarding what procedures can be considered as essential and what not from all subspecialties. And eventually each local setting will have to make their own guidelines because based on the whether the patients can travel to them or not and what can be done. But for that, if we can't, especially in cases of the repeat patients, we use telemedicines and WhatsApp if provided that we can make it safe and legal to provide information and advice to the patient and to get treatment there. Safe document because we won't know what has been done and what has been advised and what has been carried out. So this is to incorporate this. I think GICS could help develop apps and provide apps which help people to incorporate documentation into the current patient medical records. And also, I think it will be important to involve local providers, even if they're general surgeons or even just pediatricians, to actually elicit findings when you're doing telemedicine. I find this very useful, and I actually liaise with the local doctor all the time. And this again can be part of the way the patients are managed. What about the patient? I think this is important again because there will be a lot of backlog. I don't think it will be possible to increase the workforce because that is very difficult to do without training. And therefore, I think it might be that most of the workforce will work extra hours in the later when the hospitals and the transport opens up, and they might require extra funding for this extra work. And we found that many of our patients have run out of money and they might require person-to-person donations. Especially we found in Vellore, we actually needed to give them food and accommodation as well at some time during the lockdown. And I think individual donations from GICS members to support patient called what we call as a person-to-person donation, which actually focuses on patients. And with, of course, feedback on how these funds were used will be very satisfying both for the donors as well as for the patients who receive this kind of support. Next, please. Yeah, then I think research right now, maybe it's not very important, but in the long run, this will serve us very well. We have already got data on some patients to find out how many of them are able to not come. We found only 5% of the patients are able to come, and another 5 to 10% are able to get some help, but not most of the patients. At least 90% have not receiving any advice or treatment at all. So also the surgical caseload profile has changed to only the emergencies and tumors. So again, that is something that we can document now. Next, please. And I think we having had this information now, it's possible for us to go back into the patient's records and see how many could be tackled, how many actually we would have been able to deal with if we did have extra information. Next, please. Next, please. So what information we can start gathering now is the adverse outcomes that we expect and which are happening already, and delay in starting essential treatments such as in for us casting clubfoot or DDH surgery. One person with one side operated is not able to get the other side done and has a spike on for an extra long time giving stiffness, delay in removal or application of fate plates causing deformities. Then financial stress can also be assessed by interviewing families, and I think this will be important because later on when we approach donors, it would be good to show them actually what financial stress patients are suffering. And then also reviewing the patient's records for last 6 to 12 months to assess how many are missing essential visits that might affect them adversely, which will help us to actually pre-plan even before they come to see what can be done for them and call them and give them dates. For this kind of a gathering of data, students can be utilized, provide them incentives, participation in the studies that are being done, and use phones, emails, and social media for contacting these patients. And RedCap can be used to gather multi-center data. In the long run, if we have sufficient number of centers, we actually can gather a very good case for why we should concentrate more on pediatric surgical care, because we will be able to show what has happened to the patients in the absence of this care. Again, person-to-person funding for severe distress, both in patients and doctors. And I emphasize it's not just the patients who are in distress. Doctors without personal protective equipment have also suffered with mortalities like we have seen before, with their families suffering now. Then also multi-institutional studies to assess stress. GICS can coordinate them. And I think softwares can be developed to identify and create a callback system for patients to guide those who need essential follow-ups and coax them into coming. And if they don't have the money, again, help them financially. Again, the issues of local issues and fundraising can be done to assess these local issues. That is something else that can be done. And I think one of the very important things which we saw as soon as the COVID problem started, where the frugal innovations came in, using OHP sheets to create eye protection added on to the mask. And I think these frugal innovations, there can be discussion in GICS on what kind of frugal innovations are possible and popularize them. Next, please. Thank you.
All right, good day, everyone. It's a great pleasure to join this elite group of GICS experts and very good attendance of more than 94 people. I can see the chat area. There is a lot of nice comments and suggestions. What's nice actually is that most of the experts has agreed on at least 70 to 80% of the recommendation that will make my job easier. I'll try to be swift. Well, we agree that online webinars is a great tool and we can direct it to specific geographical locations to address specific problems that's local for the region. And I could see a comment in the chat area that They prefer the small focused group to the large webinars. I think both are very useful in different ways, because recently we have conducted a webinar on hypospadias attended by 500 people. That's widespread, and you can reach to a lot of questions actually on the chat area. The small group is excellent, but the widespread is another target to achieve. The YouTube videos are excellent. We can use the past, like has been mentioned by previous speaker, that it's not easy to produce new. There's a huge amount of previous videos that we need to organize and distribute. The guideline statement is very important when we start after the restrictions. What are the cases that need to be addressed first? Next slide, please. Well, we have just finished our guideline statement by the WFAPs on these items you can see on the screen. These are very important for the preparation, consultation, wards, outpatient, intraoperatively, aerosol generating devices. This is ready and will be published on the WFAP's website, and I'll send the link for you soon. This covers almost all the aspects, and there has been suggestion from the GICS experts to add some missing points of this to get a combined statement that will be very good. Next. So we already had 5 levels of priority for elective cases. That's level 1, 2, that's need to be done in within 3 months, or after 3 months, within 1 month, 72 hours, 48 hours, according to the urgency. So we have 6 levels of urgency, and this is a suggestion that also will be posted to you for as a guideline. Fundraising is of importance, of course, because this is a huge amount of work that needs equipment, human task force to finish this huge backlog. Next, this can be done, of course, through the GICS and the WFAPs together. What are the data needed? You need exactly to know what missing cases, what is the volume, what is the disease entities, and in order to have a good decision making. We have collected our waiting list with the number and diagnosis of cases. RedCap actually is an excellent way of online data collection. I'm working on it every day, and we have a lot of studies going on, either multi-center or our own data collection in pediatric surgery in different centers locally and internationally. Next, please. Well, I think that's all. Thank you very much. I hope I am within the time frame.
Okay. Thank you very much for the GICS team for again putting us together on this very wonderful webinar. So the goodness again of talking towards the end is that most of the points I'll talk about have been deliberated on by colleagues, so I'll go through them very fast. So how could GICS help with educational resources? Again, we could have information on updates on the number of COVID positive patients globally and their severity of disease. We know most places are reporting fewer children, and most of the children are symptomatic. If we can have this update, so that in the future we'll probably see how many of these children who are positive underwent surgery and what their outcomes were. And then offering emergency surgery, topics like offering emergency surgery during the community spread of COVID-19. In Africa, we are seeing, again, we are getting to the place of community spread. Some countries are trying to open up, some are still having restriction measures on board. So how do people conduct themselves during this time when they have to do emergency surgery with the fact that there is community spread, where you are having patients coming in and you might not know their status because they have to go to the OR immediately. We can use, again, formats of webinars and small groups and YouTube videos, as the previous speakers have alluded to. Next, please. How could GICS help with the guidelines? We can have guidelines on appropriate PPEs for different COVID-19 status. So what do you use for negative patients? What do you use for a suspected patient who has to go to the OR without a test? And what do you use for the positive confirmed patients? Then classification of urgency of surgery for the backlog of cases. This has been alluded to by the previous speakers to help decision making so that we don't have children who deserve to be attended to earlier waiting for a long time. Protocols on precautions during aerosol generating procedures. This again becomes very important, especially for the anesthesia part of the team, and also for the rest. How do you make sure that you're not exposing yourself and exposing the rest of the people around you? Then perioperative management of the COVID positive child who is coming to the OR. How do you prepare them pre-op management intraoperatively and the follow-up post-operatively? Once again, how can GICS help with the backlog of patients? Right now, sharing of information via webinars and email as it evolves. This is ongoing, and it also just helps people continue managing patients. Then PPEs, again, provision. Most places are still reporting lack of appropriate PPEs, and information on how to minimize misuse and optimize reuse of the available PPEs without compromising safety. Once we open and people are working or boundaries are open, GICS can help with putting together surgical teams who can travel probably from region to region offering surgery for the backlog in surgical camps. This is especially in areas where we have very few providers and still a very high burden of surgical disease in children. And this can also be used as areas where the students can be taught, where you have many patients and students who have missed having their skills during this time can attend this and be taught by the various groups of specialists. And again, GICS will help with fundraising to support the above initiatives. As we know, this will require a lot of funding. Next. In research, what we can look at is the global pediatric surgical backlog during the pandemic and the implications on morbidity and mortality. So that is information that can be collected, and we see what happens, what really happened during this time once we are out of it. And also research on outcomes of COVID-19 positive children undergoing surgery. As we've seen in the places where people have already done elective surgery on these patients, there are papers written on the outcome of patients, and it's thought that the COVID positive patient has a worse outcome as compared to the negative one. Thank you.
So, hello, everybody. It's a pleasure to be here again. My name is Fabio. I'm a pediatric surgeon from Brazil. I also speak fast because my colleagues have said a lot of things that I would like to say. I put a lot of words in my slides, but because I think that after these slides are going to be shared, so I'd like to provide as many information that I could. So first of all, about education, I think that it's very important to have material not only for senior surgeons, but also for junior residents, fellows, general surgery residents, and pediatricians. We have this experience yesterday. We did a webinar about basic pediatric surgery for pediatricians in my state, and we have more than 400 participants, pediatricians that mainly in countryside, and we think that this experience was very good. I also think that the translation of fundamental material would be very important. Sometimes we think that everybody knows English, but I have some friends, colleagues, fellows that they don't know how to speak English, and I think that's important to that GICS to promote the access for information. So we have this large team. I think that would be nice to try to translate some of the material. About the guidelines, I think that's important also to have a guidelines for institutions that don't have a lot of resource. Sometimes I read the guidelines, a lot of them talk about, for example, negative pressure or ORs, and this is not a reality, at least here in my state. So I think that's not fair sometimes to have only guidelines from high-income countries. I know that's the ideal, but we need something also safe for low resource environments. I think that we can move to the next slide, please. That I'll talk about this. I think about the backlog of patients. It's wonderful news that Dr. Shihata told us that WFAPs are going to launch the guidelines to help us. I think that would be important also to promote this international survey, probably asking the pediatric surgeons around the world which surgeries they think that should return first. I know that GICS and the program in global surgery from Harvard, we have already done this work to ask which surgeries should not cancel. We can use this work. I think that they are going to be published in the next weeks. But it's important, still important to have these guidelines to return the elective surgeries. Other thing that I think is important is to share content from associations around the world. For example, the Brazilian Pediatric Surgery Association has launched specific guidelines for tracheostomy, for the management of surgical patients during COVID-19. These guidelines are in Portuguese, they are in their website. Maybe GICS could put also these links in their website, because it could help countries that speak Portuguese. We have 9 countries that speak Portuguese, the majority LMICs, and I think that this is a way to help. Next, please. Slide. Next slide, Marilyn, please. And I think that we can move to the next, because a lot of things here my colleagues have already said. So in the end, I saw this example from the American Pediatric Surgery Association that they has launched a public Google Sheet where pediatric surgeons across the USA, they can enter data about how many patients with COVID-19 they are taking care of, they are operating, if they have tests or not, if the data that I think that also would be important, if the team are being infected by the coronavirus. So I think that probably we can work in this kind of Google Sheet or the RedCap form and made it public for, at least for us, and make it public at least for us pediatric surgeons. Then we can enter a lot of type of data, and after we can analyze even for the future generations that maybe, unfortunately, we know that other pandemics can come. So this is what I have to say. Thank you very much again, and I'll be glad to participate to answer questions.
All right, thank you very much, everyone, for Thank you very much, everyone, for very excellent presentations. So we will quickly move to some comments and questions. And I want to, from some of the questions participants have been asking, I want to first quickly come back to Susanna. There have been some comments about people that they've had to be providing surgery even without PPE. So as surgeries begin to be reopened, what are your thoughts about what to do in the absence of testing and PPEs?
Thank you, Emmanuel. That is a very difficult question to address, because there is evidence, overwhelming evidence, that we now know how the virus is transmitted. And without PPEs, we have seen that we are having a lot of healthcare workers being infected. I can give an example of my country, where partly people reopened up for electives. And in the last 2 weeks, we have seen actually a high number of healthcare workers being infected. Probably some from work and maybe some from the community. So again, with the overwhelming evidence, it will be good to insist that people in their various hospitals try to talk to their various hospital managements to try and provide PPEs where people are close to the patients offering services to avoid healthcare workers being infected, because in the long run, if you're going to allow your healthcare workers to be infected, they will go home and there will be nobody to offer services. So it becomes expensive than providing PPEs at the start. So lobbying with the various managements to try and provide PPEs is important. And two, the other thing is that in places where PPEs are provided, sometimes the healthcare workers are not using them as required. Again, education and insisting that people use them will be very important. And the lobbying should actually be pushed to the national level like we have done in our country, and continuously this should be done and explain why this is important. Otherwise, you find yourself with healthcare workers at home and there's nobody to offer services. Yeah, so in my view, there should be no compromise of saying we shall offer services without PPEs. Let us try to lobby and have, whenever we have them, again, try to use them without waste. So understanding where you are, understanding what you have and how to use it without waste, and protecting yourself is very important. Yeah.
Right, thank you very much. So Sami, I'll come back to you with the same question. I know WFAPS, you've said, has just done some guideline about surgery, what to do. So what would be your thoughts about in the absence of testing and no PPEs or PPEs are inadequate, how should we approach reopening or bringing back elective surgeries? And even for the testing, are you recommending testing for just the child or the child and the caregiver?
Well, that's a very good question. Thank you very much. Actually, as has been mentioned by the previous speaker, it's mandatory to keep our healthcare workers safe by the proper PPE and the proper investigation. But in case of urgency and you don't have the proper investigations like the PCR available, we can do some preliminary baseline studies like checking the temperature of the child and the guardians. And you can do the simple test like the CBC and the other basic tests, which can screen some, I cannot say all of the patient, but at least 60 to 70% of the cases can be suspected based on these simple studies. So again, we have a suggestion for the priority list of when we are reopening. I have 6 levels of elective cases urgency. I'll publish this on the WFAPS website very soon, probably tonight or tomorrow, and I'll send it to you all through the GICS website and through the WhatsApp group.
Right, thank you very much. And just to add a comment to that, as one of the distressing experience we have had in my institution recently, because we reopened elective surgery, and within 2 weeks, many of our interns got infected, even though we had PPEs. So I think one of the important things is the fact that we need to make sure that especially our juniors, our junior colleagues are well protected, because they don't seem to, perhaps the more senior people are a bit more careful than the junior people. And I think it's an important aspect we need to also consider.
Exactly.
So I'll come back to Dr. To Ken and Likalo. There was a comment about doing some work on what is happening with COVID and pediatric surgery and children in low and middle income countries. we are aware there are some studies going on about COVID and children, but that's all in high-income countries. COVID surge is doing something predominantly about adults. They've included some children, but in a very limited way. And it seems that there are going to be too many more questions to answer. They will raise too many more questions. So Ken, what do you think about doing a focused research work about COVID and children in low and middle income countries?
I think a lot of data is still, facts and data is still unknown with regard to COVID-19, both in adult and in children. The issue facing different countries are different, because in America, for example, there's just overwhelmed with cases to do any research. In sort of low-income countries, there's a lack of resources to do any research, so it's quite difficult. But I think for us, at least, we've been sort of publishing papers with some mainland Chinese colleagues in terms of looking at sort of pediatric clinical features in children. We published a paper in Gut recently looking at the GI symptoms of children with COVID-19, and actually discovered that about 40% of all the children with those symptoms, they have viruses found in their feces. So it is a very important route of transmission as well. There's much more work to be done. I think government in all places in the world should put in extra resources to help look into things, because it's not going to be the end of the story. It's going to be, in 10 years' time, to be another new virus coming in. So the more we do now, the more information we'll have to help and prevent sort of another disaster in a few years' time.
Right, thank you very much. Likalo, what are your thoughts on this aspect?
Yes, Professor Emmanuel, as I told you before, that we are, as a developing country, we're still working on it. We still do some research about what happened, COVID-19 for children in my country especially. As you know that we are living in as a pediatric surgeons, we are separate into some cities, and each cities, they have their own they have their own procedures for the treatment of the COVID-19 patients. But we're still working on the research. We're still working on that in my country right now.
Right. Thank you very much. I'm sure sometime before we finish, perhaps Kokila, do you want to say a word regarding the COVID and cancer in children, the work that is going on? Kokila?
Yes, I can. What is happening is that adult cancer work was, there was a multinational trial looking at the impact of COVID on the management of cancer. And we realized very quickly that the impact on children was very different, because in adult, it's mainly surgical management, whereas in children, cancer management for children includes adjuvant therapy in many of the cancers, and sometimes solely adjuvant therapy. So we've embarked on a multinational trial, including all the cancer organizations for children around the world, to look at the collateral damage and the impact of treatment and management of children with cancers, knowing that in some areas, cancer children benefited with getting all the facilities, and in some area, they were just managed palliatively with no treatment. So we've set up a multinational trial, which is using REDCap and embarking on all our LMIC colleagues who are representing international organizations such as CEOP, IPSO, GIGS, with GIGS representatives, and so forth. So we hope that every one of you who are on this platform will, through your organizations, will be able to partake in the study.
All right, thank you very much.
And just one point, that the steering committee is 75% LMIC.
Right. So there have been quite a number of comments about education and training. So Lubna, I'm going to come to you. Everybody has spoken about using teleconferences and virtual meetings. But one of the experiences that everybody is beginning to realize is most of the free versions of the meeting platforms last only for a very short time. So how do we get around the cost of having to subscribe or having the right platform to use for training? And the other aspect also is that with the limitations in actual clinical exposure to patients, what are your thoughts regarding use of simulation to continue to provide what looks like a hands-on kind of training to our residents?
Emmanuel, again, I think your questions are, first of all, what are the platforms that you can use? And I think we really don't have much of a choice. If we want to extend beyond the 40-minute Zoom free session, but we have to subscribe to the paid versions, and that can be a limitation for many LMIC settings. And perhaps that's an excellent way in which GICS can provide help provide pediatric surgeons across the world with a paid subscription in which people can use that for learning platforms for surgeons and so on. The simulations and online, that continues to be a challenge. I don't think anyone will have a simple or an easy answer to that. Clinical medicine and especially surgical care is just inherently a hands-on a hand skill in many points. There's no simulation can replace actually examining a patient and actually, performing a surgical procedure. I suspect and I know this may have a lot of opinions, but one viewpoint is that instead of focusing too much on finding alternative remote ways of learning, keep a focus on good testing, good supply of PPE, so that surgeons can continue to go back, do the procedures, and keep trainees with them, making sure that everyone is adequately equipped and protected as they come in contact with the patient. I think the emphasis should not shift from clinical care and learning during clinical care to remote learning and remote teaching, because what's missing then is that component of ongoing surgical care that needs to be provided. So we should look at it from all aspects rather than opting for simulations as an easy solution.
Right, thank you very much. Vrisha, there's been some comments about looking at mortality in cleft patients during this period and how to use apps and medical records for follow-up for some of those patients. I know you have some experience in this area, so what are your thoughts?
In what kind of patient? I'm sorry, I didn't follow you.
So the comments were, hello, can you hear me? So
yeah, I can hear you.
Yes, so there were questions about looking whether mortality in patients who are having cleft surgery, whether there's any data coming out regarding them. But I think the main thing is about how do we use apps and our records to properly monitor this kind of patients or monitor our surgeries and for follow-up?
I'm sorry, I don't deal with the cleft patients. I'm not very familiar with this. But I think when we monitor records, we may not just know what is happening by looking at the records. We may have to make actually contacts with the families. So we would require either the using social media or telemedicine platforms to contact them. Is that, I'm sorry, am I getting you right?
Yes, but the question is mainly, yeah. So are there some appropriate apps that we could use to better to maximize that follow-up in a low-tech way?
Yeah. So I actually, we found that the very low tech way and which almost gets us very good contact with the patient is WhatsApp. However, the WhatsApp is not legal. So we are forced to follow telemedicine using either the Zoom app or some of the other apps that are there. So there are 3 or 4 platforms available to us, and we tend to use any one of those which are installed on our workstations. But we actually initiate a phone call with just using the regular phone, and then we go on to the telemedicine app, and then when we need the video, we put on the Zoom app. So actually it works quite well. Most of our follow-ups now, the patient, we need to see the patient is being done, and not just by the surgeons, but almost all specialties.
Right, thank you. So, yeah, right, thank you, Richard. I will go back to the issue of how to address the backlog of surgeries. There have been a few questions about what really are I know all the speakers have said something about the problems, but just to come back to them, what really are the key barriers to address these backlogs, and how could GICS help to address those barriers? So I'll come to Veda. I'll start with you. Hello, Veda. Are you on?
Yeah, I'm on.
Right.
Yeah, I get your question regarding the backlog of surgeries, especially the elective ones during this time of the lockdown or the pandemic. I think everybody's experiencing that one, and everybody's doing to catch up with these backlogs. But really the problem that we have encountered, especially in the low middle income countries as we are, is the equipments and also the other materials that needed to address this backlog. As I mentioned in the first webinar, that since I'm working in the Children's Hospital, we have a lot of backlogs, but we would prioritize. I'm talking of on the second slides on here that we would give priorities to what kind of elective surgery that we're going to do at this moment that we're trying to go back to the resumption of the elective surgeries. So as I mentioned, the congenital defects on neonatal surgery should be taken first in foremost consideration, because I think aside of course from the tumor oncology patients, but for neonatal cases, because there are centers that in countries like us, there are centers or hospitals that they're not doing or performing neonatal surgical cases. So I would rather, as a priority, concentrate on neonatal surgical cases, but this will entail a lot of disciplinary section. We would entail the ICU, the NICU, and the rest of the staff. So there's a lot really a problem as far as going back and addressing this backlog. So as far as maybe what GICS could do is perhaps give some suggestions or some guidelines, as far as there are many heads, many very wise surgeons coming from GICS, that they could maybe give us some suggestions on how to prioritize patients to address this backlog. And maybe from this, we could gather and maybe some change our existing protocols. So maybe other low-income countries could also benefit from this. So I think guidelines should start to design on maybe some guidelines or protocol on how to suggest to address and minimize this backlog. Did I answer your question? Thank you.
Yes, you did. Thank you very much, Beda. So Fabio, when you during your presentation, you did say something about something about language and what to do for your trainees. Can you be more specific? What could GICS do to address the fact that many of the electronic training materials that are coming up and most of the webinars that are happening in English? So how could GICS specifically help in your region?
Sure, Professor. So I think that one of the most important things, it's pediatric surgery. It's very hard to nowadays to teach with the simulations that we have. So it's hard to have a proper training, especially in a LMIC, because they are very expensive. Yeah. So here in Brazil, first of all, the Ministry of Education, they decided to offer the fellows to postpone their training. So if they can do one more extra year, they are going to be okay to do if they want. So the second thing that I think that's important, as you told us, a lot of webinars that we are watching now, they are sometimes very complex and in English. And I think that's important if GICS could at least share the webinars from the other associations. For example, we have already some in Portuguese that this would help not only, for example, other countries, but also here in Brazil, because sometimes we don't have the platform, the website to share the content. And I think this would be very important. So I think that for education, this is an option to the associations could try to advise people to try to extend the training program also and share more content. I think that it's what we can do for now. Yeah. So these are my comments about education. Thank you.
Right. Thank you very much. Thank you so much, all our speakers, for a very excellent period. So I'll come back to Kokila. So Kokila, you have the floor.
All right. I think, as we said, that, you know, people's concentration wane after an hour. We've been very, very good in having an hour and 15 minutes. So from this, I'd like to thank all the panelists for preparing their slides and giving it in on time, that even during a few moments of technical hitch, the meeting continued in sync because everybody could follow the slides and knew what the discussion, where the discussion was leading to. We're very grateful for all the people who had posted their thoughts on the chat. And I think we have enough work in GICS to put these things together and see how we can put in action now rather than just talk all the time. So on behalf of GICS, I'd like to thank everybody for participating and attending this meeting. And also, you know, condolences from GICS to those areas who have lost family members or members or colleagues, and also thoughts to those of our GICS members and those of your colleagues who have contracted COVID and come around from it. So once more, thank you everybody, and I hope this is going to take us forward as a GICS community.